established that it was, this was in 2010, that it was an aggressive form of cancer, and the recommendation was then removal of bladder. We'd really, down the cul-de-sac, with nowhere else to go. And then I think from the test point of view, they call that salvage surgery, because there's always a slightly bigger risk once you've had the radiotherapy. So I was operated on in the February of last year, 2011, and we're now 12 months down the road, and I managed to get through the process in hospital in 6 days.
The main reason we are doing cystectomies here is because people present often with blood in their urine, and they've then had further investigations that have shown that they've got bladder cancer. Now, I don't want to worry everyone and think that all bladder cancers are going to end up having major surgery. In fact, it's only the minority. Most bladder cancers can be managed with minimally invasive surgery. However, there are some people whose bladder cancer is quite advanced, and it's these patients who are often going to be managed with surgery, i.e. to remove the bladder, the diseased organ, and that may be combined possibly with chemotherapy prior to the actual surgery itself.
With patients who've been diagnosed with cancer and they go on to have a cystectomy, and the mainstay of having a cystectomy is basically as a curative measure. And I know patients who've had cystectomies over 10 years ago and they're still absolutely fine.
A standard operation whereby in a man you're removing the bladder and prostate, in a lady you're removing the bladder but together with the uterus, part of the vagina and the ovaries as well, and then that's combined with removing the lymph nodes nearby and then diverting the urine, usually into a conduit but not always. That will probably take somewhere between 4 and 5 hours, that sort of order of magnitude. So it's a long operation.
So basically, with the cystectomy, once the bladder's removed, the urine has to go somewhere else. And obviously what happens is the ureters are then joined together and they use part of the bowel. A segment of the bowel is then used, if you like, as a funnel, and the ureters are connected to that, so the urine will actually go through the actual, through the bowel. And that part of the bowel is actually brought up to the skin, and it's made into a stoma, which is basically the size of a strawberry. A stoma is basically means like an opening, and it's like a conduit basically, and it allows obviously the urine to to exit through into a bag, into like a collecting system on the side of the skin. So it's a bit like a colostomy, but instead of motion, it's for actual urine instead, and it works very much in the same way as well. Once the date is given for a surgery, for a cystectomy, a patient will then attend a pre-assessment clinic, which is normally a couple of weeks before. And there they'll meet the anaesthetist, and obviously talk about pain control and obviously the general anaesthetic and the other issues they may have. Obviously a full assessment will be taken by the nurses as well.
Going into major surgery like that, there's one key thing you need to have, and that is to have a healthy body. Therefore, exercising is very important, not to be overweight. I did an awful lot of cycling and exercise, so when I went into hospital, I felt the body was well prepared for what was going to happen.
Also, normally a couple of weeks before surgery as well, they'll be seen by the stoma team. They'll go through what the stoma involves and what exactly is expected of them after the surgery. Patients who plan to have a cystectomy, they normally actually come in on the day of surgery itself, which is normally around about 7:30 in the morning. And they arrive on the day of surgery ward, where they're actually greeted by the consultant and the anaesthetist, and they obviously go through the paperwork and consent. And then obviously they're given a pre-med as well, just to help them settle down, just prior to going to surgery. And then they actually go off to have their surgery.
It's 7:30 start, you check yourself in, you go through the pre-medical sort of checks, blood pressure and everything, inquired what number I was on the list, and it indicated I was going down to surgery about 11 o'clock, 10:30, 11 o'clock, and duly that happened. So I walked to surgery with my pillows, and the rest of it's history really.
And then they go to the recovery area, where they're obviously observed and looked after until they're actually safe enough to go back to the high dependency unit, which is kind of like an in-between intensive care unit and a general ward. From there, they actually spend generally 24 to 48 hours in the high dependency unit, where it's more one-to-one nursing, and obviously got doctors on call as well.
I went into surgery on the Thursday. I came out of surgery about 5:36 o'clock in the evening, went into a high dependency unit, due there for 2 days, came out of there at lunchtime on the Friday, so that was very quick, and taken down to the ward. I was also encouraged to get up on the Friday following surgery, so the physiotherapist came round and said, "You reckon you could get up and have a go at this?" And I stood at the side of the bed hours after the surgery, really. And I guess this is part of the process of trying to get you moving quicker. I was in hospital for 6 days, and the body becomes inactive. And the other thing you've got, which I found a problem when I got home that took time to get rid of, is your muscles on your bottom and things like that, because you're in bed a lot, soften up, and it's very clear that they deteriorate quite quickly. So the quicker you can get mobility, and I think one of the problems I had at home was not being able to sit down or lie down, anything like that. And I went to see the doctor, and he basically suggested just more and more walking, more and more exercise to toughen those muscles up again, which I did. And I think the most uncomfortable thing post-operative at home was not necessarily the pain or managing the situation with the stoma, it was purely getting the muscles in the bottom so I could sit down and lie down without any discomfort. And I found that very frustrating and unpleasant. But that wasn't a surgical issue, that is purely being in hospital for too long or even lying out and about. So the benefits of trying to move people and actually getting them mobile quickly, it's got to be good.
One of the main impacts enhanced recovery has on patients is the fact that they actually spend less time in hospital, so they're less exposed to any infection.
I went into hospital on the Thursday morning for the operation, and I was out the following Wednesday by lunchtime.
When they arrive in the morning, they often arrive in a better state than they would have done in the past, having been on a noisy ward for 2 days prior to the surgery, being starved in effect, and not having, being sleep deprived. Generally, for most patients, it's recovery of bowel function that will determine how long they're going to stay in hospital. That's the major thing. So if you can get the bowel recovering sooner, then they will leave hospital sooner.
From post-operative, you've got two routes. You've got basically the stoma nurse, and the frequency of visits to her start off at monthly, then 3 monthly, 6 monthly, then annually. And I've just had one now, so I'm now on an annual follow-up on that. And then surgically, I follow up with a consultant every 6 months. And interspersed somewhere in there are CT scans to make sure that you've still got clearance everywhere else. So that's the monitoring process that's going on, and I understand that will happen for 5 years.